Hi, I'm Dr. Robert Savage. Thanks for tuning into the first podcast of a series on inhalers. Episode 1, The Anticholinergics. During this brief presentation, we will discuss the various forms of inhalers, with a focus on Spiriva. We will also discuss some basic pharmacology of the anticholinergic drug class. Of course, there will be a clinical pearl or two along the way. Chlorofluorocarbons are propellants used in inhalers. They are safe in humans, but are toxic to the environment by depleting the Earth's protective ozone layer. All CFC inhalers will eventually be extinct. So what's the alternative? Using a propellant such as hydrofluoroalkane, otherwise known as HFAs, or by using a dry powder, which does not use a propellant at all. HFA inhalers are equivalent to the older CFC inhalers, but there are a few noteworthy differences. HFA inhalers do not feel as cold as their CFC counterparts, and it is felt that they are less forceful too. HFA inhalers accumulate powder in the plastic dispenser. Just remove the metal canister and rinse the plastic with warm water and air dry. Remember, never float your inhaler to see if it's empty. You still have to prime HFA inhalers, but usually not as often as their CFC counterparts. HFA inhalers can be used with an air chamber. Air chambers hold the medication in mist form and make administration easier and more effective. Dry powdered inhalers are usually a disc or tube-like device, but it can be a capsule that needs to be punctured for activation. Dry powdered inhalers are activated by the user's inspiration, so it is important to breathe in rapidly for activation. They do not use a propellant, so shaking is not necessary or recommended. Absolutely do not use with an air chamber. The medicine will not make it to your lungs. After the first load, priming is not necessary. Many have counters, which takes the guesswork out of refilling your prescription. Clean the mouthpiece with the dry tissue only. There are two common capsule-based dry powdered inhalers, Spiriva and Foradil. They contain the medicine in capsules that need to be punctured before using. The capsules should never be swallowed. Spiriva 101. Spiriva administration is easy if you know the proper technique. First, separate the unit dose from the rest of the packaging. Never prepare the capsule ahead of time, for this may lead to accidental ingestion, and the medicine may not work or dispense properly. Loading. Open the inhaler, place the capsule in the chamber as shown, and close the lid. Activate by pressing the button on the side of the inhaler. Now the device is ready for inhalation. Inhalation. Breathe out away from the inhaler. Hold the inhaler like a hamburger as shown and breathe in briskly. You should hear a rattling or buzzing sound. Hold your breath for as long as comfortable and exhale. Open the inhaler and discard the empty capsule when done. Easy. How it works. The inner chamber loosely holds a capsule for puncture. There is a screen mesh that prevents inhalation of the capsule or any large fragments. The pharmacology of anticholinergics. Atrovent is a short-acting bronchodilator, and its onset is approximately 15 minutes, peaks in 1 to 2 hours, and persists for 2 to 4 hours in the majority of patients. Spiriva is a long-acting bronchodilator. Its onset is approximately 30 minutes, peaks in 1.5 to 3 hours, and lasts for 24 hours. It accumulates in tissues, so the max benefit is often seen in 1 week. Atrovent HFA inhaler dispenses 17 micrograms per spray, and the recommended dose for COPD is 2 puffs 4 times a day, with a maximum of 12 puffs in 1 day. It reverses cholinergic bronchoconstriction. Common side effects are dry mouth, headache, bronchitis, upper respiratory tract infections, and urinary tract infections. It should be used in caution with patients with narrow-angle glaucoma, prostatic hypertrophy, and bladder neck obstruction. Spiriva is similar to Atrovent, but with some significant differences. Spiriva does not block the M2 cholinergic receptors to the extent of Atrovent. Muscarinic 2 receptors are a negative feedback receptor. Thus, by blocking this receptor, you are actually increasing cholinergic tone to some extent. Spiriva is long-acting, needs time to reach steady state, and should only be used as maintenance in the treatment of COPD. Common side effects are similar to that of Atrovent. It causes more incidence of dry mouth than Atrovent, but this diminishes for most with time. Spiriva was believed to be associated with an increased risk of stroke, but it has been recently given a clean bill of health by the FDA. Some have been adding Atrovent to Spiriva, but is this acceptable? Both medications work similarly. The main difference is in their onset and duration of action. A recent study addressed this question. It appears that adding Atrovent increases FEV1 by about 52 mils over placebo. Statistically significant finding, but of limited clinical significance. However, by adding a beta agonist, the result is an increase in FEV1 of 137 mils, nearly 3 times the effect than seen with Atrovent. There was not an increase in anticholinergic side effects noticed in this study. In conclusion, there appears to be little advantage to adding Atrovent to Spiriva. Be sure to tune into episode 2, where we discuss the beta-2 agonists, such as albuterol. We will also address the controversy around Xopenex. Is it really worth the cost?